Assalamu alaikum. Okay, let's travel. Let's go to a journey of cardiology where you will get some of the interesting topics uh, regarding USMLE and some topics. Most of them are from USMLE inner circle, which is a very uh, high yield note for the upcoming exam. Okay, now first I would like to discuss about prosthetic valve dysfunction. Okay, prosthetic valve dysfunction. Prosthetic valve dysfunction. If I would like to talk about the prosthetic valve dysfunction, I will I would like to discuss in a different manner, like prosthetic valve. In in instead of dysfunction, it is tra it is dysfunction. So paravalvular leak. It may be due to annular degeneration or infective endocarditis, valvular obstruction or stenosis may be due to thrombosis, and the last T, transvalvular leak due to cusp degeneration. So prosthetic valve dysfunction PVT or PTV, paravalvular leak, annular dysfunction or infective endocarditis. Valvular dysfunction is valve thrombosis and the cusp degeneration. Clinical manifestation is a new murmur, microangiopathic hemolytic anemia, and heart failure symptom thromboembolism. Echocardiography should be done. In prosthetic valve thrombosis, the most common symptom in prosthetic valve thrombosis is thromboembolism. Left-sided prosthetic valve thrombosis can present as TIA, stroke, MI, bowel ischemia, TIA, stroke, MI, bowel ischemia, limb ischemia. By contrast, right-sided prosthetic valve dysfunction, right-sided prosthetic valve thrombosis can cause pulmonary embolism. So, prosthetic valve thrombosis can cause pulmonary embolism. Prosthetic valve dysfunction can come with the obstruction, really regurgitation, transthoracic echocardiogram should be done. Mechanical prosthetic valves are more thrombogenic, very high. Mechanical prosthetic valves are very thrombogenic, and you need anticoagulation. Biprosthetic valves are less thrombogenic. They only require aspirin therapy. Biprosthetic valves are it is less thrombogenic, so it requires aspirin therapy. Okay. Okay, HHT, hemorrhagic, hereditary hemorrhagic telangiectasia, also known as Osler-Weber-Wendt syndrome, hemorrhagic CVA, a cerebrovascular accident, hemorrhagic CVA, cerebrovascular accident, there may be brain abscess, paradoxical embolization across the pulmonary avium, a mucocutaneous finding like recurrent epistaxis. It can come with recurrent epistaxis. If it comes to the lung finding, can come with hemoptysis. There may be right-sided heart failure and a GI finding, chronic GI bleed. Liver is portal hypertension, high output heart failure. In patients with symptomatic bleeding, AVM, hemoptysis, management involves pulmonary angiography followed by embolization. Pulmonary angiography followed by embolization. Okay, now I would like to discuss about mm, dissection. If somebody comes with a dissection, if somebody comes with the aortic dissection, three things should be in consideration. It may be chronic hypertension. It may be chronic hypertension, cocaine, and some aortopathy like Marfan's. So aortic dissection risk factors are chronic hypertension, number one cause. It may be underlying other aortopathy, other aortic disease like Marfan disease, and cocaine. Aortic dissection usually hypertension usually present. You should look for variation in the systolic blood pressure between the arms. Variation in the systolic blood pressure in the arms, like right arm. If systolic blood pressure is 120 and left arm is 140, so variation in the systolic blood pressure between the arms, it should be in consideration. And very high, very important is severe tearing chest pain relates to the back. Tearing chest pain, back pain maximal at onset there is severe tearing chest pain. And the diagnosis in cardiology, most of the diagnosis starts with ECG, ends with echo. But in aortic dissection, you should do echo. If the patient is unstable, like transesophageal echo should be done for definitive diagnosis. But if the patient is clinical stable, then CT angiography should be done. ECG with the stir, there will be non-specific ST segment or TOF changes. Chest X-ray show mediastinal widening. As a treatment of aortic dissection, what should you choose? You should go with the pain control. You should go with the pain control. Mm, like morphine can be given, IV beta block or esmolol can be given, and sodium nitroprusside if systolic blood pressure is more than 120. Sodium nitroprusside should be given, and emergency surgical repair for ascending dissection. Emergency surgical repair for ascending dissection. Hypotension on presentation suggests aortic rupture, or other complication like cardiac tamponade, acute aortic regurgitation. Usually in acute dissection, hypertension is the must. If somebody comes with a hypotension, think about the rupture, think about the tamponade, think about the aortic regurgitation. If we look at this flowchart, if somebody comes with acute aortic dissection like abrupt onset, severe chest pain, back pain, widening mediastinum on chest X-ray, start with the anti-impulsive therapy like beta blocker, esmolol, levodopa, anti-impulsive therapy to reduce aortic wall shear stress. Aortic wall shear stress. Beta blocker and pain control, confirmatory imaging, CT angiography of the aorta or other modality if the trans esophageal echo should be done. If the patient is hypotensive, if the patient is not clinically stable, then you should go for in aortic dissection. If the patient is hypotensive, you are thinking about aortic dissection. And the patient is hypotensive, go for transesophageal echo. If the patient is not hypotensive, CT angiography of the aorta or other modality. Type A dissection confirm ascending out involve emergency surgical repair. Type B, A for acute surgery. Type B, dissection confined to the descending. So go for the admit the patient for blood pressure controlling and monitoring, and that's it. Now, what are the complications due to extension of the acute aortic dissection? What are the complications can happen due to extension of acute aortic dissection? Stroke due to extension in the carotid artery. Horner syndrome can happen. Stroke, Horner syndrome due to carotid sympathetic plexus. Acute aortic regurgitation due to involvement of aortic root or valve. Myocardial ischemia or infarction due to coronary artery ostia. Pericardial effusion or tamponade due to involvement of the pericardium. Hemothorax. Renal infarction due to involvement of the renal artery. Intestinal ischemia due to involvement of the mesenteric arteries. Lower extremity paralysis, spinal arteries. Lower extremity paralysis, spinal arteries. Aortic regurgitation may result in sudden onset, worsening chest pain, hypotension, pulmonary edema. Carotid tamponade can occur as a complication as well, but those patients with clear lung fills. Chronic systemic hypertension is the most important predisposing risk factor. Chronic systemic hypertension is the most important predisposing risk factor for aortic dissection. Marfan syndrome is the most common cause of dissection in the younger adult less than 40. Marfan comes with dissection younger patient less than 40, and aortic dissection more than 60. Think about hypertension. So suspected aortic dissection, maybe Marfan, maybe connective tissue disease, maybe hypertension, maybe cocaine user, tearing chest pain, abdominal pain radiating to the back, tearing chest and abdominal pain radiating to the back, and a perfusion deficit, pulses deficit more than 20 millimeter of blood pressure difference between right and left arm. Pulses deficit or differential blood pressure more than 20 millimeter of BP difference in the upper extremity is noted in 20 to 30%. Its absence should not exclude the diagnosis. Absence should not exclude the diagnosis. Chest X-ray and ECG should be done. Chest X-ray and ECG should be done. Evaluate and treat appropriately. Normal serum creatinine and no contrast allergy. Normal serum creatinine, no contrast allergy. Then go for these three: chest CT with contrast, MRI only if non-emergency and patient can lie still, and transesophageal echo. If the patient is hemodynamically unstable, go for transesophageal echo. Uh, what is the workup for stable and unstable aortic dissection? Initial chest X-ray, mediastinal widening, tracheal deviation. Stable is CT angiography. Stable is CT angiography. Or if the patient can lie still for long, you can go for MR angiography also. Unstable or contrast allergy or renal dysfunction, transesophageal echo. Chest X-ray. In chest X-ray, you will find widened mediastinum, aortic knob. This is the picture of the aortic knob. CT angiography is invasive but best test for determining the extent of the dissection for surgery. Now, A, that means abdominal, aortic, aneurysm. Abdominal aortic aneurysm. First, advanced age. more than 60. Another way, atherosclerosis. And another way, active smoking, active male sex, and hypertension. Mostly asymptomatic, rapid expansion, then will dull abdominal or back pain. If there is rupture, sudden severe abdominal back pain, shock, umbilical or flank hematoma management, smoking is a very important factor. Mm, for this, elective repair if the size is more than 5.5. Asymptomatic patient, elective repair more than 5.5. If it is more than 4 or more than 3, it is abnormal. So urgent repair for symptomatic and hemodynamically stable patient, urgent repair for symptomatic and hemodynamically stable patient, and emergency repair for symptomatic and hemodynamically unstable patient. If the patient is hemodynamically unstable, emergency repair should be done for a abdominal aortic aneurysm. Most commonly affects the infrarenal aorta, more than 3 centimeter. Smoking is the number one cause, male sex, older patient, family history, and atherosclerotic disease, all the age. Abdominal ultrasound in men age more than 65 to 75 who were ever smoked should go for abdominal ultrasound. Patient age more than 65 go for abdominal ultrasound in men age 65 to 75. Mostly asymptomatic, may have abdominal, back, or flank pain, lower limb ischemia or thromboembolism. Rupture often presents with abdominal distension and shock. Management is smoking cessation, aspirin, statin, elective repair recommendation. If it is size is more than 5.5, large size more than 5.5, aneurysm rapidly enlarging more than 0.5 centimeter in 6 months or 1 centimeter in 1 year. Abdominal aortic aneurysm associated with peripheral arterial disease or aneurysm. Follow-up imaging, medium 4 to 5.4 centimeters. Ultrasound every 6 to 12 months and smaller ultrasound 2 to 3 years. Abdominal aortic aneurysm occurs posteriorly in the retroperitoneum, which can delay the onset of hemodynamic 1 hour symptoms. Abdominal aortic aneurysm rupture usually occurs posteriorly into the retroperitoneum, which can delay the onset of hemodynamic instability. However, rupture may occur anteriorly also, but direct leakage of the peritoneum and rapid onset of hemodynamic instability and shock. So, evaluation of suspected abdominal or flank pain, pulsatile mass, flank ecchymosis, limb ischemia. Abdominal or flank or groin pain, pulsatile mass, flank ecchymosis, limb ischemia. If the patient is hemodynamically stable, obtain CT scan of the abdomen, CT angiography. CT scan of the abdomen or CT scan of the abdomen, CT scan of the abdomen should be done. Is no known case of abdominal aortic aneurysm? Yes. Emergency repair? No. Fast focus abdominal ultrasound should be done. If abdominal aortic aneurysm identified, yes. Emergency repair? No. Explore for other diagnosis. Explore other diagnosis. Abdominal aortic aneurysm identified, yes. Medical optimization and repair. Medical optimization and repair. No. Explore for other diagnosis. This is widened mediastinum, widened aorta, widened mediastinum. This is the rupture of abdominal aortic aneurysm. Other clues for diagnosis of the pulsatile abdominal mass, prevertebral aortic calcification, prevertebral aortic calcification on plain X-ray consistent with extensive atherosclerosis. What is the most likely diagnosis? Male smoker, chest discomfort, mm, and the chest X-ray findings below thoracic aortic aneurysm. Suggestive findings include a widened mediastinum, increased aortic knob, tracheal deviation. Initially, chest X-ray best is CT with contrast. What is the imaging modality? Is a choice for diagnosis of and follow-up of abdominal aortic aneurysm. It is abdominal ultrasound. It is cheap and does not require contrast. The strongest predictor of the abdominal aortic aneurysm, a large aneurysm diameter more than 5.5, rapid extension more than 1.5 to 1 centimeter more than per year, and current cigarette smoking. Active smoking is the strongest risk factor, and one-time abdominal ultrasound male active smoker age 65 to 75 to rule out the abdominal aortic aneurysm. What is the what abdominal what abdominal aortic aneurysm repair complication results in progressive abdominal pain and diarrhea, bowel ischemia or infarction? What abdominal aortic aneurysm repair complication results in progressive abdominal pain and blooded bowel ischemia or infection due to inadequate perfusion after the loss of inferior mesenteric artery during aortic curve placement? What are the most likely what are the most common peripheral artery aneurysm? Popliteal. Second one is femoral, frequently associated with abdominal aortic aneurysm. So go for ultrasonogram of the abdomen. If somebody has popliteal cyst, if somebody has popliteal cyst, then other other leg should be evaluated that there is popliteal cyst also in there too, and you should go for femoral. You should look at the femoral and you should do ultrasonogram to look for abdominal aortic aneurysm. So we have read prosthetic uh, prosthetic valve dysfunction. We have read aortic dissection and abdominal aortic aneurysm. Hope you enjoyed.